having us back. I'll bring up my screen here. And tonight's topic is management nuances and pitfalls of the cervical spine in patients with a high T1 slope. Somewhat of a niche topic, but hopefully by focusing it, we'll be able to talk about a lot of golden nuggets. So general overview of the talk tonight, we'll review some major important cervical alignment parameters. We'll present what the T1 slope is as part of that discussion, and more importantly, what it represents. And then we'll talk about the nuances of management options of the cervical spine in patients specifically with high T1 slopes. We'll then present three cases. The first will be presented by Anu Botbold, although she may be in the OR, so one of our neurosurgery fellows has kindly stepped in for her, Rahul, moderated by my partner, Aaron Clark, and good friend. Then two of our fellows, Matt Easton and Mo, will present cases moderated by Shane Birch and Sig Berven, respectively. So 1,000-foot overview of cervical alignment. There are three major parameters that I think are key to understanding this talk, but also to keep in mind when looking at these types of patients. The first on the far left is the C2 to 7 Cobb angle. The middle image talks about the C2 to 7 SVA, which is drawn as a distance from the posterior superior corner of C7 and a horizontal to the plumb line of C2. And something over about 4 centimeters is considered abnormal and increases disability. And then on the far right, the T1 slope is drawn from the superior end plate of S1, and the angle that is created with the horizontal is the T1 slope. Now, the T1 slope is a critical radiographic parameter because it really helps determine cervical spine sagittal balance. This is a very important paper that was one of the first to define this. And it clearly comes in a lot of variations. As you see on the left, a low T1 slope corresponds to a certain type of cervical shape. And then a high T1 slope is one that also dictates how the cervical spine is aligned. There are differences in terms of what's considered quote unquote high or abnormal, again, in quotes, greater than 20 degrees, but some people push that to greater than 30. And a high T1 slope, the reason why it's important is because it's really the lighthouse or gateway to what may be happening below the cervical spine in the thoracic and lumbar spine. So a high T1 slope in these little cartoons can either represent a primary, can be driven by hyperkyphosis of the thoracic spine or by hypolordosis, so flat back of the lumbar spine, or a combination of the two. Now, in this setting, the cervical spine can behave in one of two ways. With compensation, if it can compensate with hyperextension of the cervical spine, this is represent a flexible cervical spine and one that may not have a lot of rigidity and intrinsic deformity, versus the patient who has the inability to hyperextend and has this high increased C27 SVA, and that represents kind of concomitant cervical deformity as well as a thoracolumbar deformity. And there is a continuum of pathology, and a flexible spine, as you see on the far left, can quickly or slowly and over time start to lose its lordosis, become flat, and then start to increase its head thrust forward with an increase in the C27 SVA. Now, I try to think about these patients in two different categories. So group one are those that have preserved cervical lordosis and relatively normal C27 SVA, less than 4 centimeters, and those that are starting to have their head thrust forward, they lose their cervical lordosis, and that C27 SVA increases. Now, in the group one, as you see on the far right, you can have the standard cervical stenosis at multiple levels. But another unique type of stenosis that occurs in these types of patients, which is from the hyperextension compensation for the thoracolumbar deformity, is a C3-4 stenosis. As you can see in that middle image, it's just an isolated stenotic picture, and sometimes will also be associated with a spondy. So I have started to see that and then think, okay, that may also be a marker of something that's happening further down. Now, when you start to progress from the group 1 to the group 2 category, where you lose that cervical lordosis and you start to become, frankly, kyphotic or increase your C27 SVA, the spinal cord starts to become put on stretch and tented over the anterior column. And the reason why this is important or problematic is that as you get stretch through the Poisson effect, you start to get increased pressures intramedullary. This has been shown in several cadaveric studies, and with this leads to myelomalacia and worsening of myelopathic scores. So if we look at management of the patients based on their type of group, so the patients in the group 1 with good lordosis, I think you can think about these patients as relatively standard in terms of their management. The classic consideration, this is a picture from Ortho Bullets that talks about patients having 1 to 3 levels in non-rigid kyphosis being addressed from the front. And then those that have multi-level stenosis, 3 or above, posterior operations are more of the mainstay treatment. Now, I think there are some nuances that you should consider with these patients with hyperextension of the cervical spine that occurs in the setting of a high T1 slope. One is if you are addressing the distal levels, so say a C7 T1 or even a C6 7, or one of the levels at the top, that there may be difficulty in access, the clavicle, the mandible. This is different than in patients who's kyphotic, where there is a relatively smaller incision, you can access everything. And then speaking of access size, when you have to be able to have your line of sight be somewhat directly in line with the disc space, if you're trying to access one that's lordotic at the top and then more kyphotic at the bottom with 3 or 4 level ACDF, that incision length may get quite a bit higher. Exposure may be a little more challenging. And whether this increases dysphagia, I think that may be debatable, but these are just some things to keep in mind when you're planning for your surgery. Also plating, because of the hyperkyphosis that is required to maintain an upright gaze in these patients, when they're supine, that hyperextension may go away. So you may iatrogenically flatten that cervical spine and create a cervical kyphosis, not frank kyphosis, but you may just take away that compensation that they need. And so they may have now more difficulty in terms of their sagittal alignment globally. This may result in hyperextension through the distal segments or above. And then the other thing that may occur is that the bottom level, because of the shear forces and other forces at the distal segment, you may have fractures of the vertebral bodies distally in these really hyper lordotic cervical spines. Now, when it comes to the posterior approach options, laminoplasty and laminectomy, it's important to talk about how cervical alignment affects outcomes. And this is a nice study actually from the UCSF group that looked at patients with greater than 20 degrees of cervical lordosis to start versus those at less than 20. There's a sub-analysis of the groups and found that laminoplasty patients, not surprisingly, significantly more improvement with more lordosis, where that wasn't the case in the laminectomy infusion group. And so you could think, well, good lordosis begets good lordosis. 80-year-old with cervical stenosis, high T1 slope, and laminoplasty at 4, 5, and 6 maintained his lordosis postoperatively. That being said, it is important, though, to understand that even in the setting of good lordosis, a high T1 slope may portend a negative result when it comes to maintenance of your lordosis. This is a nice study of 64 patients from a Korean group that looked at high T1 slopes versus those that had low T1 slopes. And they did find that there was significant more loss of lordosis postoperatively in the patients with a high T1 slope. You can see it in a diagram they provided in their paper of someone who started with good lordosis in the setting of OPLL, and then after laminoplasty decompensated, maybe back to their normal resting state and rather than the compensation state. So this also may hold true for the posterior cervical fusions. Good lordosis pre-op begets good lordosis post-op if you can bend the rod appropriately. It's actually a case of Aaron Clark's that he kindly shared with me that ended up doing really well. But that's not always true. He did a good job, and I'll show you a patient of mine who I thought I didn't do as well of a good job in terms of maintaining her lordosis. That lady had a couple autofusions in her cervical spine, high T1 slope from that hyperthoracic kyphosis. She was hyperextending her cervical spine and was myelopathic and did a C2 to T1, and you can see had loss of her cervical alignment, flattened her out, which definitely increases the risk of screw pullout, distal junctional kyphosis, and non-union at that level. So when it really becomes a slippery slope are when you start to have progressively increasing C2 to 7 SVAs and concomitant kyphosis. So you can see these patients all with high T1 slopes and going from a mild head thrust anteriorly to someone who's nearly decompensated. And wanted to chat about why these are particularly challenging for posterior-based operations. One, in both laminoplasty and posterior cervical cases, you disrupt the tension band, which is what's allowing them to keep their head up as is, but it's already compromised. And then with a posterior fusion group, you may fix this tension band in an abnormal position, which can create abnormal biomechanical situations. So the way I think about these types of patients, the laminoplasty, you open up the tension band, disrupt its ability to contract as it was before, similar to a drawbridge. If you cut these things that are keeping it up, the head's going to fall forward and the bridge is going to fall down. We did a study several years ago looking at 4 groups based on their preoperative CSVA and their T1 slope, and all laminoplasty patients and those with a high T1 slope and an increased SVA were at highest risk of loss of cervical lordosis. This has also been demonstrated by a Japanese group in 2016, where an increased C2-7 SVA more than 4.2 centimeters and advanced age were predictors of post-op kyphotic alignment following laminoplasty. This is a patient of mine, started off, not a terrible deformity, C2-7 SVA of 3.7 centimeters, which is within, quote, normal, and then got worse postoperatively by nearly 2 centimeters. A patient also with worsening posture after a laminoplasty. Again, not a very significant, quote, deformity, but relatively high T1 slope and became, frankly, kyphotic postoperatively. This also may be an issue with loss of the tension band for short posterior cervical fusions, and something very similar can happen. Good example of this, patient had a high T1 slope, 31 degrees, was treated outside with a C2 to C6 and created a pretty significant loss of their head thrust because of that increase in the distance between C6 and C7, the focal kyphosis distal to the instrumentation. This was actually a case that was presented at the Seattle Science Foundation. Because I was giving this talk, I had to take a picture with my iPhone of the screen. Lady who had a cervical thoracic deformity, treated with a C2 to C4, and then very quickly postoperatively, as you see on the right, had a wildly decompensation of her cervical alignment distal to it. I think for the same reasons we have just talked about. Now, another part of this that we should discuss is in the posterior cervical fusion groups, if you go long, the way I think about this is you fixate so that posterior tension band in an abnormal position. You don't restore the alignment. Their head is still thrust forward, similar to a cantilever. The head's falling forward. Their shear force is going to be pulling out the distal screws, increases non-union, DJK rates. And this can put a lot of now fixed pressure on the trapezius muscle, the paraspinal muscles, which can cause quite a bit of disability. Patients start to develop a bit of a webbed neck because of that constant ability trying to keep their head up. And over time, this can be very disabling. The reason I know about this is because I've done it. This is a lady and caused this problem. So C2 to T1 stenosis. She actually had multiple myeloma and had a fracture 3-column through C6. And we treated this with a C2 to T4. I was concerned about stopping at T2 because of the risk of DJK. So I went down a couple levels and cemented her, but didn't correct that, mid-cervical flattening, and that cervical forward thrust remained, and she was miserable. So eventually got around to doing a T2 PSO and brought her head back. And it really made me start questioning, well, should I have done this from the start? And I don't really know the right answer to this. And maybe that's something that we can all discuss as a group. But these are challenging situations because many of these patients don't come in with a primary complaint of deformity. Many times they present just with a neurologic complaint. So I think the options here, the short segment fusion, probably not the wise decision because of what we've talked about with the tension band being compromised. So long segment fusion, I think minimum is advisable if you need to do it from the back. C2, the upper thoracic. And then if they do have a deformity that manifests because of that fixation, then do a stage deformity correction like the case I just showed, or talk with them about an upfront deformity correction with C2 to the lower thoracic LIV, with deformity correction with an osteotomy in the upper thoracic spine. Now, I won't belabor this too much because I do want to get to the cases, but just quick overview of choosing the ideal location for an upper thoracic 3-column osteotomy. Should it be C7, T1, T2, T3, or below? We did a study several years ago, multi-center or dual center with Johns Hopkins, combining our cases of C7 PSOs with those that were in the upper thoracic, and found that any type improved sagittal alignment. They had high complication rates. The lower cervical osteotomy, so C7, provided greater cervical SVA correction, shorter operations, but had more complications, longer hospital ICU stays compared to upper thoracic osteotomies. This is a courtesy slide from Chris Ames, looking at what are the neurologic risks, at least when it comes to palsies at the C8 level, comparing the different osteotomy levels. The C7 and T1 levels have quite high C8 palsy rates, the T1 being the highest. Unclear mechanism, where T2 and T3 or below had very, very low rates. So if you are going to choose it, and if there's not a strong reason to do it at one level or the other, this is a good reason why you should choose T2 or below. This is an example of patient Aaron Clark and I took on together. I think patient started with a high T1 slope, 45 degrees, 2-level ACDF, followed by posterior cervical, C3 down to C7. And again, the head now remained fixed, having some distal junctional kyphosis. And we treated with this with a T2 PSO, extended him down to T10, and he did quite well. Now, this is the lady I showed before. This is a case that we ended up doing a C7 PSO on, and had no issues. C8 was just fine, but so it's not a no-go zone. It's definitely an option. So choose your osteotomy as you see fit based on the type of deformity. Now, where to stop distally? There's a lot of discussion about this. If patients meet certain criteria and they do want to have a deformity correction with an upper thoracic osteotomy, stopping below the thoracic apex, T9, T10. Should it be the stable sagittal vertebra, as been proposed for Sherman's kyphosis, or should it be just stopping at the first autofused disc? I don't know the right answer to this. I think they're all reasonable. Probably in this situation, if there's autofusion, say dish in the thoracic spine, you don't need to go all the way down to T10 or the stable sagittal vertebra because you're just trying to protect the distal junction from subsequent kyphosis. So I think this probably is a reasonable target. So in conclusion, high T1 slope patients represent thoracolumbar sagittal malalignment. If you only have a cervical spine X-ray, it'd be incumbent upon you to obtain full spine X-rays just to get a full assessment of their alignment. They do pose challenges, especially those who are addressed with posterior operations. We talked about the disruption of the tension band, risk loss of lordosis, DJK, and iatrogenic cervical thoracic deformities. Anterior operations, if you can get away with them, probably are advisable. And I do think, and this is how I'm approaching it, if the patients come in with primarily neural symptoms and their alignment's not really the cause, presenting focus, try to focus an operation on the neural structures. And then if they do develop a post-traumatic deformity, then addressing the deformity at a later time. Whereas if those come in with neurologic symptoms and a deformity, or if the primary complaint is deformity, then I think it's wise to address that deformity with the appropriate technique, upper thoracic osteotomy to 2 or below, or if it's primarily lumbar deformity, then correct the lumbar spine. And then the LIV, we talked about a couple of options. So
Hey, Alec, can I ask a couple of questions before we move on?
shoot, yes.
Great presentation. And the questions are really about, and I don't know how easy it might be to get to your first slide looking at cervical lordosis, SVA, and T1 slope. And the questions are, and actually one's a comment. The first question is, what's the norm for cervical lordosis? We've kind of got the norms for all the lumbar parameters. That's question one. Question number two, in looking at the CVA, your point of it kind of looks in the middle of C2. Isn't that kind of a subjective starting point? I think there's a potential for inter-observer unreliability in terms of that measurement. I mean, is there more of a standard for putting that upper point in C2? So those are the two questions. And the comment is T1 slope is something that we're looking at now in arthroplasty. And I'm sure one of your three cases is going to be an artificial disc case. Kidding. That in the higher T1 slopes, when we're doing a C6-7 disc, we try to stay away from less constrained prostheses. But that was just a side comment. But the first two questions, I really want to know.
Yeah. So to the C27 SVA point first, this image is not actually fairly truly accurate. It's not drawn from the back corner of the posterior. It's more the superior posterior corner. That's problem number one. Number two is the point in the C2 body should be there's a lot of different areas that it can be measured from. It could be from the tip of the dens. It could be from the anterior inferior corner of C2. The recommendation is to put it in the mid body of C2 because it's not affected by the C2 slope, which can be something that's changed with compensation for the cervical spine. I'd love other people's comments on that. In terms of the normal cervical lordosis, I don't think, this is similar to the lumbar spine. It varies based on the T1 slope. We know that there are different shapes based on Rousseli. So there are patients with a quote unquote higher T1 slope that inherently will have a higher cervical lordosis. And then there are patients who will have a lower T1 slope. Say someone who has a Rousseli type 2, that will have a straighter cervical spine. When I was a fellow, I wrote a paper with Mike Kelly looking at the different Rousseli types and how the cervical spine changed into alignment and lordosis. And there was so much variability that we couldn't come up with really normal values. And I may be missing something. So if other people know, please chime in. but there is variation, I think, based on normal
So we don't have
shape of.
we don't have a parameter like lumbar lordosis within X% of pelvic incidence. We don't have the equivalent in the cervical spine yet.
Uh, Not to my understanding. There may be a formula, but I can't think of it on the top of my head right now. Apologies.
I agree, Alekos. I think what you pointed out is there's a terrific amount of variation. And in fact, the normal T1 slope variations, as you indicate, can be 30 degrees or higher.
All right.
So we don't have we've got a T1 angle compared to the mandible. We really don't have a clear idea of what how there ought to be a match between that T1 to mandibular angle and lumbar lordosis. Yeah.
And then, at least in the thoracolumbar spine, there's been a focus now on this T4 L1 hip axis, and I wonder if something soon is to come when it incorporating the cervical spine, taking those values into account. But I think TBD. So for cases, this is a first case, and I will let Rahul and Aaron Clark take it away.
Hi, and thank you for having me. I'll do my best impression for Anu, who can't be here. But continuing the theme, this patient was a 78-year-old who presented to our clinic a couple of years ago with progressive gait instability and neck pain, as well as some urinary urgency. He had a medical history that was notable for all of these things that are written here, including coronary disease, sick sinus syndrome. He actually also relevantly had a stroke in the recent past, and the reason the myelopathy was eventually diagnosed is that the patient had, made gains with physical therapy to the point where he could walk with a cane, and then he regressed back to needing a walker over the course of a couple of months. So by the time he came to see us, when we saw him on exam, he had pretty significant hyperreflexia with positive Hoffmans and weakness in the hand intrinsics bilaterally. Didn't have any overt like bowel dysfunction or numbness tingling anywhere. If you go to the next slide, you can see the patient's post-operative imaging. We have like a standing cervical x-ray as well as an MRI. The MRI, I think, is a pretty clear picture. You see the patient has multi-level, at least 4, maybe even like 5 segments of cervical stenosis circumferentially. If you look at the x-ray, like we talked about, this patient's T1 slope is probably on the order of like 45 degrees with respect to the horizontal. And it's incompletely compensated for by the cervical C27 lordosis here. I think the 27 sagittal displacement is about 6 or 7 centimeters at baseline. If you go to the next slide, so we diagnosed this patient with radiographic and clinical evidence of cervical myelopathy, and we proposed a 3 to 6 laminoplasty with partial dome laminectomies at C2 and C7. You go to the next slide. The operation was uncomplicated, and the patient had a uncomplicated in-hospital recovery. Typically, when we do these cases, we have the patients use like a soft collar, at least when they're out of bed or for comfort. We saw the patient at about 3 or 4 months post-operatively. At that point, they had some persistent like neck stiffness, even though I think the remainder of their symptoms were stable and they had recovered quite well and done pretty well with PT. They did remark to us at this point that they felt like they were having a much harder time keeping their head up. So if you take a look at the next slide, we obtained these x-rays, I think, at the time of this clinic visit or shortly thereafter. And you can see a couple of things. Like we have our hardware placement for the laminoplasty from C3 to 6, but the patient has had relative loss of the pre-existing C2 to 7 lordosis. And as a result of this, has progression of their SVA compared to even the preoperative imaging. And this was evident to us even on physical exam that the patient was unable to keep their head upright without significant effort. You go to the next slide. If you go to the next slide, the patient, like I said, we did kind of offer them additional surgical intervention, but I think the patient and their family felt like it wasn't necessarily worth the benefit, or that perhaps that the lack of ability to keep the head upright, while bothersome, was not so much so that it would necessarily motivate them to agree to do additional surgery. The patient's also seen in a neurology clinic, so they essentially clinically diagnosed the patient with Parkinsonism, or like a Parkinson's plus type of syndrome. Somewhat interestingly, he actually has like a fairly long-standing history of falls, even preceding his diagnosis with us, and had like a negative DAT scan at some point in his past, even before we saw him. The family also essentially declined to undergo further testing because they didn't feel like the diagnosis and the treatments available would necessarily justify the time of doing the test. But for those reasons, we sort of recommended that the patient kind of undergo physical therapy. And like I said, they declined surgical intervention. I think that is,
yeah, thank you very much, Rahul, for summarizing that case of mine. I really hope we get some discussion from the panelists around this, because I do feel like my approach to this patient was very similar to what Alekos had mentioned in his initial talks, where I think both the neurologic side of things, with the severity of the stenosis and the patient's primary complaint of myelopathic symptoms, combined with really significant medical history that I think would push a surgeon towards a surgery that's not as large in magnitude as perhaps a multi-segment fusion. I'm very interested to see what people think about this. My hope was to decompress the spinal cord here, to at least prevent progression of the patient's cervical myelopathy. And I knew we did have more corrective opportunities if the patient did develop this type of post-operative problem. But I'd love to hear everybody else's thoughts. Dr. Chapman, I see your hand up.
You're muted, Jens.
Sorry, guys. So, Aaron, I'm proud of you. This is awesome. We are doing way too many laminoplasties, and if there's one laminoplasty ever so often that goes sideways, it's worth it. The outcomes, the complication rates from everything that we now know are so much lower compared to multi-level fusions. And the Zohar comparison study is really probably the best way to look at this. So this is really cool that you did this. Now, the contraindications that I have seen and that are eminent, and we always know these later on, are, as we all know here, myopathies or neuromuscular disease. So in retrospect, alcoholics, people who can't actively fire the extensor muscles, which is obviously classic for Parkinson's patients, are the main at-risk patients, but that's retrospectogram. I'm glad you tried it and you did it.
Now, philosophically, we agree that you try to do the least amount of surgery to help the patient's symptoms. Do you think that we just had this great lecture from Alekos on T1 slope. Do you think the T1 slope influences your choice with doing a laminoplasty versus kind of your C2 to T2 instrumented fusion, or how do you factor that in, the T1 slope?
Yeah, I think that's kind of the big question here. And I would say, without an extremely definitive answer, it's definitely something that I look at and I measure in clinic, and it's something that I factor in. But I think, to Dr. Chapman's point, it in of itself is just a numeric value would not solely push me towards doing a more extensive either cervical thoracic fusion or deformity corrective maneuver, in addition to the decompression of the spinal cord compression. Part of it has to do with a difference in how I counsel a patient, where I would discuss with them, particularly in a patient with a high T1 slope, but also, any patient that I'm recommending a laminoplasty for, is there is the chance that, the goal being to decompress the spinal cord, maintain motion, but there is the possibility that they would need some additional operation in the future if they develop postoperative kyphosis or neck pain or things like that. So I think that's a good point that I don't have a super definitive answer for.
But Dr. Clark, just hypothetically, had you done a C2 to T2 fusion in this patient who turns out to have Parkinson's, that would have been a disaster also. That patient would have had a very hard time to get better. He would have kyphosed at T2, T3, or wherever you are stopping. So that's without a question. This was just an unfortunate neuromuscular disease or neurodegenerative disease that you just try to help, and we get burned on Parkinson's more than any other condition. So
I agree. Thank you.
To the group, and I'm not advocating for it, but just for food for thought, are these the type of patients that we should consider doing an operation from the front to help, keep a little bit more lordosis, and then do a front back operation to help or to maintain the lordosis, or at least something at the distal junction to help maintain it? I don't know the right answer, but I wouldn't have done anything differently, Aaron. But I have noticed that when patients have high T1 slopes, this is not an uncommon occurrence.
What we've seen some of the deformity guys at TBI do is maybe target a level or two from the front to keep that from happening, Alekos, because as we all know, multi-level anterior surgery in older patients is just fraught with a lot of complications.
And Alekos, I was going to ask you that about your myeloma patient. In 2020 hindsight, maybe doing a 2-level or even a 3-level ACDF in front would have spared that patient from ultimately needing a T2, posterior osteotomy and a longer fusion. You have to weigh which is the devil is worse in which hand, you don't know. But and then similarly to this patient, would bringing their their head back basically, and throwing their midline back towards a more neutral position, keep them out of trouble with the distal junction. Good questions, but we unfortunately don't have good answers. Nobody has a series of these clean enough to make that determination.
Yeah. Yeah, and even a hybrid construct. I've done several where I just fuse the C6 to T1 and then do laminoplasty above. And for these patients, they still kyphose through the laminoplasty segments above. So I don't know if protecting the bottom with a fusion is ultimately going to move the needle here. All right, so we'll go on to the second case. This is presented by Matt Easton, one of our current fellows coming from to us from Michigan, and the moderator will be my colleague, Shane Birch. Matt, take it away.
Cool. Thank you so much for having me. So our patient is an 81-year-old female, past medical history of hypertension, hyperlipidemia. She presented to our clinic with worsening neck and upper thoracic pain, as well as kind of an increasing pain with any sort of neck extension. She has an extensive surgical history. So she had a T9 to pelvis with interbody fusions done in 2018. And then in 2020, she came to our clinic with radicular symptoms as well as some mild myelopathic symptoms. And so we did a C4-5 ACDF and a C6 corpectomy. 2 years later, she had recurrence of her radicular symptoms. So we did a C2 to T1 posterior cervical fusion in 2022. So after that procedure in 2022, she had good relief of her arm symptoms and actually had significant relief of her back and neck pain. But then over the subsequent 2 to 3 years, she developed worsening neck pain. She had undergone, multiple non-operative modalities with minimal relief. This is her pain diagram in clinic. This shows the location of her pain predominantly at that cervical thoracic junction. And then next slide. Next slide, Dr. Theologis. And so this is her standing X-rays in 2020 after her lumbar procedures. And you can see she has a high T1 slope of 37, but then her thoracic lumbar parameters are well aligned. So we can go on to the next slide. And this is her MRI from 2020, once again demonstrating that significant stenosis and some myelomalacia. Next slide. So this is our postoperative imaging from her anterior procedure. T1 slope was 40, and then relatively good C2 to C7 lordosis, and then a mismatch of 22 degrees. As I said, she initially did well, but then had recurrence of her radicular symptoms. And we can move on to the next slide. This is after her C4 to T2 fusion. And once again, her slope has increased a little bit over the subsequent 2 years, and her lordosis is about the same. And then next slide. And so these are the X-rays we got before, most recently when she was coming to our clinic. And you can see that her T1 slope has increased significantly to 55 from 39 5 years prior. She has that T1 slope, cervical lordosis mismatch of 35. Her cervical SVA is 40 millimeters, which is kind of right on the cutoff of what we would say is uncompensated. And then I just kind of gave her her pelvic parameters. And, I think this is kind of a good example where you can see that her C7 SVA is normal, but she has a malalignment in the cervical spine. So next slide. We ended up performing a revision C2 to L2 with a T6 PSO to correct her T1 slope and essentially connect her cervical fusion to her lumbar fusion. And these are just some standing X-rays. On the next slide, we have some radiographic measurements. So her T1 slope, we corrected almost 25 degrees. Her lordosis, cervical lordosis remained about the same, 15. And then her mismatch is down to a 10. Her cervical SBA is at 23 millimeters. And then her lumbo-pelvic parameters did not change. And then next slide. This is just some outcome measures, kind of looking at her pain scores over the subsequent subsequent surgeries. And next slide. And that's just her ODI. And that's what I got.
Nice presentation, Matt. I think this case represents, she's got a high 1T1 slope, but, she's been fighting this thoracic kyphosis, all of her life. She never really presented with thoracic back pain. She had a lot of lumbar pain for her index surgery. And, we just kind of knew that was going to come back to haunt us down the road. But I think the other thing that's maybe lost is that her neck pain really flared up when she lost the ability to maintain horizontal gaze, or she would fatigue. And so she's very active, 81-year-old, and her neck was killing her because she couldn't extend her neck anymore. And so a lot of the procedure was for realignment so that she can get horizontal gaze, and which I think we achieved. And one of the complications you can get from these procedures is you can get dysphagia. So if you straighten them out too much, it flattens out the esophagus and they get dysphagia. And she actually has, a moderate form of dysphagia, which she's working through, and I think it'll get better. But if you absolutely crush the alignment here, you get burned by dysphagia. And so it's one thing to bring up. But overall, she's pretty happy. She's very active. Her back pain scores significantly better. It's improving. Her ODI scores are pretty good. Her NDI scores are good. So overall better, but she's still struggling with dysphagia. And she's about 6 to 8 months out.
Shane, beautiful case. When did she really start to struggle with the horizontal gaze? Did the posterior cervical operation tip her over the edge, take away some of that ability, or just something that was chronic in nature?
Honestly, like when she came in with being profoundly like myelopathic, I tried not to go into the back because I didn't want to disrupt the tension band, and so that's why that construct was just from the front, because I didn't want to get into like what we eventually got into. But I had to fix her and decompress her from the back because she had some persistent radiculopathy. And then I think as soon as I did that, you could see over a couple of years like where her neck started to go down. And then she's just trying to lordosis through the upper cervical spine, and then she becomes, as time goes on in her age, she's in the 80s now, she becomes arthritic. And then so it's a layered effect. I don't think it's one thing, but it's just like you add a bunch of things up, especially in older patients, and the whole is sometimes greater than some of the parts, but some of the parts are important to look at, I would say.
Definitely. Beautiful outcome.
Thanks.
Any other questions? All right. If there's no other questions, we'll go on to the third case. This is going to be presented by Mohammed Al-Amoudi, one of our fellows coming to us from Canada, the Canadian tradition at UCSF, and it's going to be moderated by Sig Berven. Go ahead, Mo.
Thank you, Dr. Theologis. I just want to answer a couple questions from Dr. Blumenthal. Dr. Berven encouraged me to answer this. I was going through, literature review, preparing for my presentation, and some of Dr. Berven's talk answered some of the question you had. In regards to the first question of what is considered normal cervical lordosis, there's been a study by A. Fallon et al. They looked at morphology of spines from C2 to C7. And as it turns out, actually, 32% of them were kyphotic and asymptomatic. So as Rosalie probably would look at, there's no such thing probably as a normal lordosis. Some actually could be kyphotic and normal. Some with small lordosis, some with sigmoid kyphosis, some with straight kyphosis were asymptomatic. And then the other question about the plumb line, the C2 plumb line, there was a study that was looking at quality of life measured retrospectively using different plumb line numbers, C2, C1, and the external auditory meatus versus the C7. And in all cases, I think the real giveaway from that study was that it's actually a trend. There's no real cutoff that people usually use of 4 centimeters. It's kind of a linear trend. And as a number increases over 7 centimeters, that number doubled almost from less than 1 centimeter, sorry. And then I think the last question was the T1 slope. I think T1 slope and thoracic T1 inlet are two relatively good new ways to look at kind of like the lordosis effect from the thoracic level. Apologize for that segue, just if I wanted to answer the couple questions you had.
No, that was great. Thank you.
Okay. So the case I have here is it's a 68-year-old female, otherwise unremarkable in the past medical history, presenting with neck pain. For the most part, it was dexterity issues and symptoms and signs consistent with myelopathy. This has been going on for years, so it's chronic. Her physical exam consistent with myelopathy. All the special tests and hyperreflexia were positive in her. This was seen by an outside hospital. And so next slide, please. These are the images that was obtained from the outside hospital. And the films on the left represent the extension and the films on the right represent the flexion, lateral x-rays of this individual. And as you can see, some of the most striking features in this X-ray is the spondylolisthesis between the level 3 and 4. It's a very high grade there. And while the displacement is more or less the same, the angulation increases with flexion. And another striking feature here is the elevated kyphosis. Even at extension, it's sitting at 16 degrees, and with flexion, it goes to about 22 degrees, C2 to C7 Cobb angle. And then if you look at the cervical SVA, that's also quite elevated, both in extension and flexion. Next slide, please. So because the patient had myelopathy, advanced imaging was also obtained, including MRI, and there are central stenosis both at C3, C4. As Dr. Theologis has alluded, there's high chance of central stenosis with these deformities, but also at the level below at C4 to C5, as you can see on the cross sections on the right there. Next slide, please. So the index surgery, as I mentioned earlier, was done at the outside hospital, and they elected to do a C2 to C6 posterior spinal instrumented fusion, as well as decompression. Next slide, please. So this is how it looks like postoperatively. And as you can see, this is the C2 to C6 construct. And then the measured cervical lordosis, or rather kyphosis, is 22 degrees. So they basically left the patient at the kyphosis in their flex position preoperatively with no deformity correction. And then the other thing that you can notice in this X-rays is that the C3, C4 high-grade spondy was also left where it was, and the cervical SVA was elevated. I measured about 4.5 centimeters. So this is the immediate X-rays post-op. 6 months later, she comes back. Yeah, thank you. 6 months later, she comes back with the same symptoms, dexterity loss, pain, and her deformity actually progressed. So next slide, please. So these are the repeat X-rays at 6 months, and you can see that this patient went on to develop distal junctional kyphosis at the level just distal from where the construct was made. And she went on to develop 32 degrees of kyphosis now. It's much worse than where she was preoperatively. Even at flexion position, this is significantly increased. And her spondy remains high grade, and her cervical SVA, as I measured, was about 6 centimeters. So quite elevated. Significant derangement in her quality of life. So this patient was quite unhappy. So next slide, please. So the revision surgery was performed, and at this time, the revision addressed several things. As you can see here, she had a C2 to T3 revision, posterior spinal instrumented fusion. You can see that she had also a anterior cervical discectomy and fusion from C3 to C6, and the deformity was corrected from a kyphosis to a 15-degree lordosis. Her cervical SVA was reduced to less than 3.5 centimeters, so quite well aligned there. And the anterior posterior view is shown on the right side as well. Next slide, please. So a couple of discussion points. I'll finish this presentation, then we can talk about some of these. Would you have predicted this to have failed from the immediate post-op? So this is kind of a very common procedure, but this patient presented with several unique features. So perhaps those are some red flags that may have made somebody curious as to how to solve the problem differently. And then secondly, why they failed to choose a lower instrumented vertebrae away from the junction. And then the other thing is the C3, C4 high-grade spondy was not addressed. So those are a couple of things that perhaps may have led to the first outcome. Next slide, please. So this is following the index procedure, and this is following the revision procedure. Next slide, please.
So as for the sake of time, we'll open up to discussion.
Thank you.
Maybe I'll start the discussion here. Mohammed, thanks for presenting that case. I think that some of the thoughts that we've gone through here in terms of why do laminoplasties fail, why do anterior cervical cases perhaps fail with kyphosis, and why does a posterior cervical case fail with kyphosis, is I think understanding the center cranial of mass has got to be part of this. We've been focused on sort of C2 to C7, C2 to T1. But I think understanding where the center of the cranial center of mass is, the CCM, and this is an interesting one because oftentimes there's a lot of compensation get between the occiput and C1. You see here on the film to the left how the ring of C1 is sitting right up against the occiput, and although there's a lot of potential compensation there, I think that compensation is the equivalent of somebody hyperextending their hips or trying to bend at the knees. It's really unsustainable. I think the simple gravity of a 8 to 12 pound head and the tension, as Alekos has indicated, on the LIV is similar to long fixation to the sacrum. We're pretty routinely using pelvic fixation in long screws, and this is where if there's any question about residual sagittal malalignment, I've got a very low threshold to anchor this to T2 generally in an analogous way to where I would anchor this to the pelvis. I think the other thing you're seeing here that I'm a big advocate of is anterior column reconstruction. I revised this case some time ago and just did the high-grade spondy, the 3-4 to 4-5 and the 5-6 anteriorly. I think at this point, I probably would also extend that across the cervical thoracic junction to try and get some better support across the cervical thoracic junction. Again, analogous to what we're doing at L4 to S1. Any other comments or questions, or Scott, Jack, Jens, when are you crossing the cervical thoracic junction anteriorly?
Hey, Sig, this is Amir. Can you hear me?
Oh yeah, Amir, great.
Hey, I think you bring up some great points here. And one of the things I think we haven't talked a lot about today is, that high T1 slope. I really worry about something kind of underlying in the thoracic spine. And we've been really focused on the cervical deformity, but if you have a bad thoracic deformity, a short segment fixation like this is very unlikely to work. And whether you want to, just go to T3 or sometimes it would require even more. But again, I think it's very appropriate that you guys bring up these cases because it's really showing that there's more to just that small short segment that we may be focused on.
Yeah, Amir, I think you're bringing up a really important point there. Is sometimes, in general, when I see a T1 slope of more than 20 degrees, although that can be in the realm of normal, I think that the subaxial cervical spine has a tough time really getting C2 back into alignment when there's more than 20 degrees of slope. And the first thing I think about is that that's somebody who needs a long-standing film. And I think that's the point you're making is identify what's going on below T1 that's causing that to be so high. Again, that can be normal, but if there's pathology below there, that probably ought to be addressed first.
Exactly.
Yeah, I think that's one of the major take-home points of this talk is that people should be cognizant of the high risk of failure of just treating the cervical spine in patients with a high T1 slope. They are set up for abnormal forces as a result of what's happening distally. And like I said, I don't think all of these patients require a huge thoracolumbar realignment, but the patients should be counseled a priori about these types of risks and that something bigger down the road may be in their future because rather than just say, oh, this happened and then talk to them about what's at stake next. I think setting those expectations appropriately are critical for taking care of these patients.
Alekos, this topic really started in a debate in our Hawaii course where one of our speakers suggested that the ideal person for a laminoplasty has got a high T1 slope. Another of our speakers said I would tend towards fusing a patient with a high T1 slope. And that alone, I think, really remains relatively unresolved. I think one of the real take-home messages here is to, number one, high T1 slope, look for thoracolumbar deformity. Number two, when we're doing a laminoplasty, do all we can to try and preserve our tension band, right? Certainly our muscular attachments to C2 as well as C7, and to the extent we can, a good fascial repair. And number three, in our neuromuscular patients, perhaps leaning towards a fusion rather than motion preservation.
I think this is a great lesson for us degenerative people, who tended to just focus on our area, and starting with fusing somebody in the lumbosacral junction as a flat back, and not anticipating that that's going to throw the more proximal spine out of alignment. This is sort of it, kind of in reverse thinking, but these cases really do highlight the importance of not being so segment specific that we fail to recognize the genesis of the problem, and that we're making the problem worse. So, thank you guys for your, Alekos, as you said, finding your little niche here in today's lesson. So, as always, you did a wonderful, wonderful job. Thank you for being our partners.
Thanks,
Great
everybody.
cases. Thank you, guys.
Thank you, guys. Great cases.
All right. Take care, everybody. Stay safe and get your CMEs.
See you next time. Bye.
Bye-bye. Thank you.
Bye.
This one's non-CME, Dr. Ziegler, but that's all
Okay.
right.
Oh,
Really? How come?
why?
Yeah.
Maybe we'll talk offline.
Okay.
Okay.
Bye, Corey.
Bye.
All right. Bye, guys.